All right, guys, it's Mark. I appreciate you all joining us today on our live stream. I apologize for being late. I made the genius move of not calculating UK time well, and Mick so graciously has jumped on an hour earlier than he had planned. So I thank him greatly for that. Today I'm excited to have Mick Thacker with us today. He's a really world-renowned researcher and getting into some high-level research on predictive processing. Some of you guys know a little bit about it, some of you don't, so we'll get into a little bit of the background behind that and some of the discussion pieces around that. But without further ado, I want to bring Mick into the discussion. Mick, do you mind just introducing yourself to the folks?
Not at all, Mark, and thank you for asking me to join you, and privileged to join all your viewers stroke listeners. Yeah, my name is Dr. Mick Thacker. I'm a physiotherapist by background, trained to be a physiotherapist and qualified in the UK at West Middlesex University Hospital in 1987. I worked as a jobbing physiotherapist between sort of 87 and 95, really. Studied advanced studies in manual therapy, MACP as we have over here, IFOMT approved, managed to gain distinctions throughout. Thought my career was going to be in manual therapy. The better I became at manual therapy, the more I realised it didn't really do very much for many people. At first I thought that was me, imposter syndrome, not being good enough. As I began to get more confident in my abilities, I realised it probably wasn't only to do with me, but there were some severe limitations. Being a little bit more analytical, I started to sort of look at outcomes, look at the reasons why, and one of the big reasons why I was treating a lot of people with persistent pain. That brought me back to sort of one of my passions in life. I'd done some work on what I thought was pain at the time, but in fact was clearly about nociception for my A-level studies, my advanced level studies at school, where I stimulated both dragonflies and woodlouse, and some of your viewers, listeners know that I have an ongoing passion for dragonflies and I'm considered an expert in a particular type of dragonfly, so I spend a bit of my time still dealing with that. Anyway, did my MACP, realised that I was really not making the benefits or changes I wanted with patients, saw that they were largely pain patients, returned to my sort of passion for pain, went off to UCL where I did a master's degree. Because I'd done the manual therapy, I was given a lot of slope to actually get out of what was effectively an MSc in physiotherapy, and ended up doing an MSc in neuroscience and started to work directly there with people like Clifford Wolf, Bruce Lynn, Pat Wall. Steve McMahon was still coming in and out. At the end of those studies, went off to start my lecturing career at Brunel University. And in talking to people like Pat Wall, Steve McMahon, Steve Thompson, who had shifted across to Guy's and St Thomas's Hospital, they offered me a PhD. So I actually did my PhD in molecular neuroimmunology of neuropathic pain. So basic science, PhD. I'd got a pretty good science background, but obviously was well out of my depth. As I say, my main talent in the world is not being bothered to look a fool in sort of the eyes of very clever people, and I've been very successful over the years of looking a fool in front of very clever people. But I was proud to say that I was the first and the only physiotherapist who did a PhD supervised with Pat Wall directly. So I supervised by Pat and Steve McMahon, who in his own right, Professor Steve McMahon is a world legend in the world of pain, and Steve Thompson, whose career sort of probably hasn't quite gone down the pathway that he intended it to, but getting married to sort of a doctor who goes to the South Atlantic, etc., took him away from London. But they were the people I got to thank. So I did my master's project with Cliff Wolf. So, I've got and Bruce Lynn. So I've got a fairly good background in working with some of the world's best people in pain. After my PhD, I realised that, I was really looking down a microscope, moved to doing some neuroimaging at the Institute of Psychiatry with a pain group led by Steve Williams and Dr. Matt Howard, doing some really beautiful cutting edge sort of neuroimaging. Together we supervised sort of several students as well, did a unique sort of postdoc there, did neuroimaging. At the end of that, realized I knew even less about pain than I thought I did. So started to work quite closely with a bunch of philosophers, sat with people like Tim Bain and David Bain up in Glasgow, talking about my ideas about pain and whether philosophy had the chance of making a bit more sense of some of those outstanding questions, and slowly worked my way to make contact with Andy Clark, Professor Andy Clark, who's a professor of metaphysics up at University of Edinburgh. We started chatting, and I thought it would be interesting to do another PhD in philosophy. So I'm doing a second PhD in the philosophy of pain based on a predictive processing framework. And that's pretty much where I am. My day job is I'm an associate professor at London South Bank University, so I'm the professional lead for physiotherapy there.
Sounds like a busy career, and sounds similar to a lot of the travels. I've also navigated the manual therapy and seem to be maybe not farther along as you are, as of course, in questioning some of my thoughts and abilities with my hands. I've listened to a lot of your work in podcasts, and obviously I'd love to get into some of those discussions. But before we do get into those discussions, predictive processing for maybe the person who's not really well read in it or well versed in it, how would you go about explaining that to maybe a clinician who's kind of new to the concept?
I think the simplest way is to say like it's effectively turning the somatosensory system on its head. Traditionally, we thought as things being driven by specific inputs that enter via sensory transduction in the periphery. As long as certain conditions are met, an action potential is generated centrally, causes obviously discharge at the next synapse. Again, if certain criteria are met, then you get onward travel throughout the neuroaxis up to the brain. And that's the traditional view, the old thing that we were all taught at college. The first order neuron goes from the periphery to the spinal cord, second order neuron goes from the spinal cord up to the brain, and the third order neuron is internal within the brain from the lower regions to the higher regions. And no one in predictive processing is questioning whether that neuroarchitecture exists. We also have known through beautiful work of people like Key Ren, Ronald Dubner, Howard Fields, etc., Alan Basbaum, all working in the States at the time, that also, there's this discharge also from the supraspinal areas back out, which is not a motor discharge, but actually is what most people refer to as descending modulation of pain, a term I'm not comfortable with, and I hope as the podcast goes along and this discussion goes along, people will understand why not. But this was a bidirectional system. What predictive processing posits is that, in fact, actually the brain is always trying to make the best guess to infer what is going on in the periphery. So it is always making predictions about what the likelihood is of you coming into contact with a particular stimulus, and obviously tries to predict that. So what it's saying really is that the downward, the descending predictions actually are what come first. And then the sensory inputs are used, if you like, as a frame of reference against that prediction. Is that prediction accurate? Is that prediction not accurate? If that prediction is accurate, then obviously prediction meets input, and that input can be explained away perfectly by the prediction. However, if that prediction is not actually in tune, if you like, with the incoming sensory information, then the prediction will be updated. And that will happen in two ways, and generally those occur at the same time with no temporal difference. And that's one of the key differences between predictive processing and something like the neural matrix theory, favoured by obviously people like Lorimer Moseley, one of my best friends in the world. So that actually what predictive processing says you will try to update the model by both an action, but also by neuroplasticity, dynamic plasticity to retune the synaptic gain, etc. So if you've learned about sensitization, if you've learned about wind-up-like phenomena, if you've learned about any of that advanced neurophysiology of pain, all of that is subsumed into this model, in my opinion, perfectly. You don't have to throw any of that out. It is, in my opinion, a better way of looking at things than the matrix theory because of some of the reasons I've said. So that simply put is what predictive processing is about. And sorry.
Yeah, I think that's a great summary of it from my limited understanding, but that I think helps a lot of people get a good, at least basic grasp on what we're talking about here. I think it's interesting when you think about this model and kind of traditional views of pain. You alluded to some of the neural pathways and some limitations of that view, and how this view how we have these internal models that we build that kind of we're ascribing a comparison to whatever the incoming sensory input is from the world around us and our sensory experience. I'm curious, in pain, where do you see maybe from a physiotherapy perspective, where do you see us maybe struggling from a maybe application of this type of model to where it's how we traditionally look at it from a physio aspect, and maybe how incorporating this might help us update some treatment models and treatment methods to better reflect current science around what we're understanding with predictive processing?
Okay, sorry, Mark. I actually missed a big chunk of the first bit as you went down. Okay. I think the transatlantic gremlin. Sorry. So can you just repeat that?
So I'm just wondering, with predictive processing, I'm wondering with pain and how we understand it from a physiotherapy perspective and how we treat it from a physiotherapy perspective. I'm wondering how you think our current treatment approaches and methods we use in physio could be better updated with predictive processing frameworks and theory in mind.
Yeah, I think one of the things to say about predictive processing, if you want it to, it can look very brain-centric. And again, any of your listeners, viewers who have know particularly my more recent writings have said, well, I'm not brain-centric, so I'm not just jumping to the brain. I think one of the powers of predictive processing is it gives equal weighting or appropriate weighting, which is a better term, to either the periphery or the brain, and actually helps you reason whether your treatment should be focused more centrally or more peripherally, in my opinion. So that's a way that I think it is going to really help physiotherapists going into the future. That quite often people sit in either the camp, they're peripheralists, still focus on peripheral inputs. Some people have obviously made the move to sort of what a lot of the cynics would say, they've become glorified pseudo-psychologists. They're using more CBT, ACT techniques. I should call it ACT, of course, for the purists, mindfulness methodologies. And this doesn't sit very comfortably with someone like myself, because, again, it's just dividing the person, the human being, up into these sort of two sort of almost dualistic sort of perspectives. I'm going to be controversial and say the most dualistic people I've met in my therapeutic career are psychologists, because they think that everything occurs within the brain and within the higher centers, and of course we know it doesn't. So I think that one of the real beauties for going forward is actually that predictive processing can offer this sort of idea of where we should treat. At the same time, I mean, it's duly respectful to things like the mature organism model of Louis Gifford proposed. Again, a great friend of mine. I've just come back from his son's wedding, actually, in Cornwall. So, it's a sad loss to us all, and I want to put a big shout out to Louis, because I know he was much admired in America, and some a great friend. But again, these predictions become better the more mature you've got. The more mature organism model really actually sort of fits in beautifully with this sort of type of perspective. So if you've been treating people based on the mature organism model as a physio, I think you probably have been largely treating them from a predictive processing point of view. One of Louis' biggest quotes was top down before bottom up. You've got to prepare people for what they're about to receive. Having said that, as I say, I think it allows us to make a decision. So we need to probably go a little bit deeper, if we may, way into sort of why that's the case. The bit of predictive processing, I think most people are frightened with, particularly if they go to the work of people like Carl Friston to begin with. Carl is a very lovely human being, but also incredibly clever. By no chance he's widely tipped to be the next Nobel laureate, so from all the indices. But I think that what the basic Bayesian sort of framework, and again, I'm not going to sort of give a tutorial on Bayes here, but it fits in perfectly with what we just said. If you make a prediction, the prediction is not matched by the input, then actually you have to update the prediction. That's basically what Bayes is really about fundamentally. But what it really is, once you go a bit deeper, it talks about priors. So priors are these predictions, or the model would actually establish it. And it's important to say these models are not just generated in the brain, they're generated at every hierarchical level of the nervous system. So that's an important part of predictive processing. It's a hierarchically generative concept. So each level is predicting what occurs at the next level. And if the level predicts accurately the level below, then obviously there's no prediction error and no message is passed any further up the nervous system. So, much of what's happening day to day is dealt with perfectly by the predictions at each level of the nervous system. You don't need to be consciously aware of, for example, as I look at you, you've got your beautiful Under Armour shirt on, and you're not aware of the colour until I mention it to you. And then suddenly you may think, all right, my label tucked in, is my table not out? I brought it into your sensory consciousness. Mm-hmm. And I probably updated your predictive models, okay? But you're sat comfortably and made no adjustments, so your predictions are great. But these priors obviously are templates, if you like, against which you will then match sensory input. So again, it's very important that when we deal with people, that we are trying to understand their priors. What is the current model the person's working with? As soon as I say that, it makes it think that we're talking about some sort of model of pain out there, but I'm not. I'm talking about a model of expected sensory input as well. So the other great thing for me is predictive processing covers both the reductionist but the more holistic sort of perspectives of pain. And again, we can talk about that a little bit more later. But I think the key thing is that if we know that priors, which are particularly what are called, what I term as tight, and people in the predictive processing world use probability density functions, these sort of, graphs that again often put people off. But what they're really saying is how much variance is there in the prediction. So less variance would equal a more accurate prediction, a more precise prediction, and that's given greater weighting in the nervous system. So, for example, I would look at something like central sensitization as something where the spinal cord is producing, due to all the neurophysiology, a very precise prior for nociceptive transmission. In other words, at the dorsal horn, it's very likely that information will be passed to higher centers. So even if it's not just in origin. Yeah. So that's why I help explain allodynia, for example. So when we deal with these priors, but equally the priors could be dominating from above. So we've got to try and work out in each individual where the priors are most precise, and therefore which part of the nervous system is most likely to be dominating in that person's presentation. So if we've got a really precise prior at the dorsal horn, we might need to either make that prior less precise, and that could involve an whole group of peripheral-based therapies, so it still supports peripheral-based therapies, or we could actually do something more centrally, higher up, to try and make those priors, the models there, more precise than the precision at the spinal cord. And if it does that, then we'll shift away from that very higher prior at the spinal cord and shift that to higher parts of the nervous system. So we've got choices. We can either play with the inputs, or we can play with priors. Yeah. So, and again, I think that's what physiotherapists, physical therapists have done. They just don't know they're doing it. And I'm not here to teach anyone to, my granny to suck eggs. There's some people who can, some of your viewers, listeners would probably say, little fat boy probably hasn't got big enough hands to manipulate someone or do something, well. So that's why you couldn't get anyone better. But I'd like to think I was fairly good at manual therapy. And the only reason I say that, you need to have the confidence. You need to know about your own abilities so that you know whether it is you or whether it's something else. Yeah. So obviously we should all ask questions in the clinic. Is it my inabilities, or is this truly something else? And the more confident you are in your handling skills, your assessment skills, your knowledge, your perspective on these things, then I think the more confident you are to make the right decision for the person in the clinic.
Yeah, I love what you said there, because I think that's something, colleagues and I discuss as far as when you start moving away from just an input-centered way of kind of playing with the patient's, I shouldn't say playing with their experience, but kind of, trying to influence their pain experience, that you kind of, when you're moving towards more the neuroscience and predictive processing models and looking more from the priors and the top-down way of looking at it, you get kind of labeled sometimes. Not by everybody, but as well, you just must not be good with your hands. It's just you're obviously a failure of a physio. You should be stripped of your manual therapy credential and just forced to live a life of terrible clinical practice. But so I unfortunately I think that narrative still is pervasive in our profession here in the States. I can speak for, because I know for me I've had that same thing discussed with me. Well, Mark just probably isn't as good as the experts are with their hands, but I think you give a good, rendition there of, if you're confident and you've trained and you've gone through all these things, maybe there's something else to it, and maybe there is that top-down way we got to look at it. So I'm going to put a question up from Tim Beams was on. He had to run, unfortunately, but I know you know Tim a little bit well because he's over in your neck of the woods.
Tim so we must say that Tim did a master's degree with me. We've taught together. We know each other well, good friend. So, just want to be explicit. It's not a Fed question, so I don't know what he was asking, but I know Tim very well. Yeah.
He asked, where, if at all, will we start to uncover weaknesses in a predictive processing model for understanding pain?
Yeah, so where are the weaknesses? And that's a great question, obviously, for someone who's putting that out there. I think at the moment, the biggest weakness is that we don't have an amazing amount of clinical data that sort of by which we can test predictive processing against. We've got emerging data from neuroimaging, from artificial intelligence, from sort of, if you like, the more theoretical constructs. In terms of turning attention to patients and predicting how they may respond to a particular intervention, then that has begun, but it's in its infancy. But again, there's a lot of work in the mental health arena, a huge amount of work, particularly in schizophrenia, what used to be called hysteria, in autism, etc. And in terms of sort of people with persistent pain problems, then there's not enough people looking at how this sort of model fits. Now we make predictions to treatment, etc. A spin-off of this experimentally is we can use a thing called dynamic causal modeling if we acquire the right type of data, and that allows us to build models which again will then make a prediction of who's likely to make a positive response or a negative response to a particular treatment. That's a spin-off of predictive processing. And probably the purists would say it was there before predictive processing, but it certainly can be used within a predictive processing modeling system. And that's something that I'm at the moment working on together with a group of people, including sort of Carl Friston's group, etc., to sort of try and see how we might bring that into physiotherapy. Katia Weiss's group in University of Oxford, well-known neuroimager in the world of pain, working with Irene Tracy. Katia, we lectured together at a recent conference in Reading, and she showed some nice work where they're starting to look at predictive processing models in drug therapy for pain. So, I'm particularly keen over the next period of time to start to develop some of that data for physical therapy from the clinic. So, but the weakness is at the moment, clinical application, clinical data is lacking.
Okay. I'm going to put another question up here because we had kind of discussed it a little bit, but James Stark asked, can predictive processing explain the meaning response, kind of the placebo, nocebo effect, as he sees a strong relationship in his clinical practice of that as far, and it makes sense to me maybe from the priors and some of the expectations generated and different things from our language and our words and from our contextual effects around our interventions.
Yeah, absolutely. I mean, if you said where is the body of literature relating to pain in predictive processing at the moment, it is in the placebo, nocebo arena. So you've got people who are experts in that field. So Christian Buchel's group in Germany, particularly De Rijder's group in Holland, they've written a series of papers that say, yes, if you make a very, as I call them, tight priors, and again, I reiterate, my nomenclature comes and my hand signal is because of people using probability density functions. So if you get these very highly precise, non-variant priors, so if you establish one of those for a positive effect of treatment, then irrespective of the treatment, so if you like, the treatment then becomes the input, the prior, the very tight expectancy overrides any beneficial, and in the case of placebo, non-beneficial, non-active, we should say, component, and you get the response to the prior, not to the intervention. Equally, if you set up a very tight prior, a very precise prior for a negative outcome, it doesn't matter, irrespective of, again, the input here is the treatment, is a treatment which somebody is expecting, and as the context of that treatment has been negative, then they will have a nocebo response. So, there are some beautiful papers, and I'm quite happy to sort of send a wealth of reading to you, which in some way you may be able to link to this and for your listeners, viewers, that wouldn't be a problem. But there's a body of work, and there's some lovely papers come out and using predictive processing as perhaps the best way of looking at those particular phenomena, both the placebo and nocebo response. Yeah.
No, I think that's great. I think it makes sense with what you're saying, and what we see sometimes when you've had a return patient who's been through your clinic and really had positive experiences. And some of the high-level mentors I've worked with will even freely admit this. What I think is a strength of being a little humble with their skill set is that sometimes the outcome's almost there without the before the patient even gets the hands laid on, as far as the priors are so there and strong, ready to have a positive response, that you can be able maybe sloppier with your technique, or maybe not perfect, whatever perfect is, of course, with your technique. But as long as that therapeutic ritual that generates that prior is there, that it can generate. When that's a hard pill to swallow, though, for a lot of folks, because it's usually how we're reared as physios, is that it's all about our technique, it's all about our input, to kind of piggyback off of that, because this is me. Did you have something you wanted to add, Mick?
Oh no, I think that what I would say is, it's about the environment, the context, the expectation set up. It's about you. So I think in the past people have also made that sort of almost reduction in themselves. It's about their hands, but it isn't. It's about them. It's about how they conduct themselves. It's about how internally consistent they are as well, because you can imagine if the person has a particular expectation, a particular prior of you being very good, very diligent, you've got a good reputation, but they've never seen you before. They come in and you're having a bad day and you've been sloppy, or you haven't tied it up or whatever. You can create those mismatches. So maybe it puts a huge pressure on you to be consistent within yourself and your approach and how you are. But that shouldn't really be any need to say. You must treat everyone with the utmost respect all of the time, 100%, and they are your mum and dad and your brother and sister, as long as you get on with all of those sort of people. But they are your most beloved people, every patient that comes in. Certainly as a clinician, how I practice, that's certainly how I try to get anyone who passes through me to practice. It's just how you conduct yourself, but internal inconsistencies are a big issue, I think, in the clinic that haven't been thought about enough.
No, that's great. to kind of, and this is maybe my bias speaking, because you brought up some great points of your careers in your manual therapy training. And my fear, and this is me from my personal experience, is that we're at risk for manual therapy to kind of become an irrelevant mode of treatment if we don't update our methods and update our thinking processes around manual therapy. Are there any big things that you think that would be a necessary movement in the manual therapy world that would really help manual therapy stay relevant within pain care versus kind of still very input centric, tissue-centric approach, because you can also, the other extreme is getting way too brain-centric, and I think the strength of this approach is that we have to recognize both the periphery and central in creating these sensory experiences and comparing them to these priors. But I'm curious what your thoughts would be on like manual therapy and where you feel that field needs to travel to remain a relevant player in care of people in pain.
I mean, I think, we're always in danger. I mean, we know there's some powerful voices in social media. I'm not sure how well qualified some of those voices are, to be honest, compared to their group of followers. I mean, I think most people should be made to state their Kardashian index, which is the number of papers you've published and been cited against how many followers you have on social media, and consider if you've got a Kardashian index more than 4, then perhaps you're a little bit fraudulent. Fraudulent inverted commas before I get sued. So, we were talking. Your kid may come in, so that's great. So she can come and join us, or he can come and join us. But I think there's a massive. This. I've had it for pretty much 20 plus years of my career. Are you telling me as a physical therapist you should keep your hands off everyone? And the answer has always been across those 20 years, no. It's just knowing when to put your hands on people. But if you do it, commit to it fully, do it well, do it in a dosed way that is not going to do any damage. Have a good idea about why you're doing it. What is your intention? It's your intention. I don't think really now, if you said to me, I'm doing this for an analgesic effect, I think we now know, unless you want an analgesic effect that is pretty low level analgesic effect and very short lasting. I do advocate to everyone, if you ever done the technique and you do an objective retest, and they look better, wait 5 minutes with doing nothing else and do the same test, and you'll find that 90% of your people went back to how they were in the first place. So, but know why you're doing it. But certainly, the sort of reasons I would still advocate for putting your hands on people is all the things we know about therapeutic touch, and there are people who are more experts than I about those things, about building an intimate, professional, intimate repertoire, rapport rather with your patient. It's comforting, if your child was to come in, he probably wants to come in to be physical with you,
Mm-hmm.
That was a physical barrier, we are gregarious creatures. We thrive around other people, not everyone, but most of us do. So there's a huge non-verbal communication going on by handling. The other thing is quite often it can be used to reassure people that actually their tissues are strong, are healthy, can withstand things. I don't manipulate people anymore, but I have used manipulation in the past, safely, not above the shoulders, but to demonstrate that actually, and wanted to obviously produce a cavitation and a crack to sort of show people I'm prepared to do things to their tissue, just to reassure them that the tissue is okay. Mm-hmm. But not, I think it's how we set those things up, if you like. It's how we set the prior to the treatment and what we're really trying to do with the treatment. Am I a massive fan of manual therapy? No, but nor am I an opponent or opposed to it. It's got to be used judiciously. But I think those old ideas about, of course, the neurophysiology is there. If you want the neurophysiology, I'm comfortable with my neurophysiology to tell you why those sort of things might work within a PP framework or within a traditional framework. But it's pretty low level effect, and short lasting effect, and I don't think we can get away with trying to pretend we're making a difference at sort of, that sort of neurophysiological level anymore with manual therapy.
Yeah, my daughter almost made an appearance, but her mother has grabbed her and brought her to daycare. But unfortunately, we weren't able to get her on. But I think that's a great perspective on manual therapy because it's balanced. It doesn't mean, because I think when people come in with what they ascribe to be, a healing response and a healing ritual, which is sometimes hands-on care, I think our hands can become part of that. I just hope we become aware of all that goes into that response more than just the inputs at the tissue.
Yeah, and I think what's really important is, manual handling. Manual therapists have generally been taught a higher level of examination protocol. We've still got to ask our techniques. It's the question about whether our particular procedure, particular test really is specific, sensitive, and diagnostically accurate for what we're using it for. But that fact that you've demonstrated to someone that you've done a very high level, often physical examination of somebody, I would advocate that all manual therapy screening includes a high level sensory testing. In the past we've said, well, it's got to be indicated, can't do everything. But I think a sensory test is always indicated because we will miss subtle signs of sensory change, which are indicative of a problem that is either already present or is emerging. So I think that, again, that sort of level of demonstrating clear, effective handling, it's very reassuring. It shows people that you've been bothered, you've taken time to try and find out what their problem is. And that's something quite unique to our profession. I mean, other professions do it too, eh? But, we're talking about physical therapy. It's something really unique. If you go to see an orthopod, generally might, if you've got a knee problem, do an anterior jaw, a modified Lachman's, may get the arthrometer out, may do 3 or 4 things, but it will probably be a maximum 3 or 4 things in a very short space of time. Most physical therapists take at least, I would hope, half an hour to fully assess one, at least, and I hope longer than that if they're given the provision to do so. And so I think that's a really essential point. And it goes back to what I was saying before, is if your manual handling and your examination and your assessment and your reasoning, which is obviously integral to that, is accurate, you can trust what you find in the clinic more. If you think, I'm not very good at that test, how the hell are you ever going to interpret that test? Because you'd always have to say, could that be me? Was it the way I did it? That's what I was trying to make the point of to begin with. I'm proud I was a manual therapist. I'm proud that those skills taught me a high level of examination, a high level of reasoning. But I'd like to think I was always engaging, not being brain centric, but, I was always engaging, both ends of the spectrum,
Absolutely. To kind of come back a little bit to some of the discussions you had earlier, you had mentioned, the thought of priors that these patients have that kind of can be very precise or maybe non-precise, and correct me if any of my language is wrong, of course. But I'm curious, in the examination and kind of the interview of a patient, does that make it seem like it would be more important to be a good, to understand what those priors are and know what their past sensory experiences are, what their past, pretty much life experiences that have influenced maybe some of these priors that come into your treatment room? Would it in your mind make the patient interview become even more important as far as to understand those priors?
Yeah, I mean, and I'm going to be slightly facetious, but I think you'll allow me. Priors don't come into clinic. People come into the clinic with prior. Okay, and I think that's a really important thing to say. That we deal with people, and we deal. You're right. So it's a bit naughty of me, but it's very important to who I am, and I like to think those people who know me, I'm consistent at pulling up bad semantics when they're there. Not that not that I don't have them myself, because we all do, hey? But it just can strengthen the point that people come in. But yes, of course, they're coming in with all of this past experience, so we go back to things which are inherent. Now, I might have seemed a bit unfair on the neuromatrix model, but I think the neuromatrix model now is 20 odd years old. It's got to be out of date. Nothing stands the test of that much time, just as PP will be out of date, I hope, in 10 years' time. There'll be something else to be interested in and focus on. But it will inevitably have drawn on some of the vital stuff that emerged from that particular perspective. So I think in the mature organism model, which after all was heavily influenced by the neuromatrix model, and then, Lorimer's neurotag model, which I know, he gives due credit to Dave Butler and Louis for pretty much turning him back to being a physical therapist, because he was about to leave the profession until he went on their course. His models have emerged out of that particular perspective as well. And so, yes, of course, the neuromatrix model, predictive processing, mature organism model, all those things say, look, all of these inputs have always been coming into this sort of already established sort of series of models, neuroplasticity, thoughts, feelings, behaviors, emotions. So you're having to sort of consider all of those things and take them into account. I think what you've got to sort of start to establish is again, back to your point, and you're right to perhaps pin me on it in a very kind way, is, what we're dealing with is, do we start by, we want to educate everybody in this day and age, but again, sometimes that education can be done through your hands. And I would argue, if if your priors are of sensory information, you need to try and establish a rapport with that sensory input. I think, there's a movement in predictive processing not to call it that, but I think it's still worth calling it sensory input. But all I'm meaning is the input that goes from the tissues to the sort of spinal cord, and that's sort of it. It's not going up and abated to the brain. So I think we need to really start to sort of say, look, if we see when we think things, if we can reframe things like sensitization as being, in my opinion, which it is, a hyper prior as developed in a part of the nervous system, then we either need to change that prior directly, or, like I said, treat elsewhere. But I think for me, I'd always want to try and directly address the prior, not just try to make another prior more precise than that prior, because otherwise it's there. It will probably, come back once the person's gone back to their sort of day-to-day life without you. So you need to do something about that as well. So, I've been accused, I'm unloved by everybody, without there's a sort of huge, argon up across America. But you see, the brain centrics don't like me because I'm advocating the periphery. The peripheриsts don't like me because they think that I'm advocating the brain. But I think that's the beauty of PP. You can't advocate one or the other. It's always a dynamic interaction between, the nervous system, either higher or lower, and when I say that, I include our periphery sensory apparatus in that too.
Yeah, no, I that's a great perspective. I think with manual therapy, like I said, I just think sometimes we forget that piece. I'm just speaking again from my experience in discussions with colleagues here, and I know there's a lot of manual therapists and folks doing some amazing things and incorporating a lot of this stuff. I just think sometimes we, can jump to both, extremes and not see that middle point that you beautifully kind of portrayed there of making sure the periphery and, because the body doesn't cordon off the central nervous system and the peripheral nervous system like we try to categorically do it to better understand it, but then it kind of limits our ability to put the pieces together with patients.
I always say to people, look, if you just take a time just to look at some of the terminology, if you're particularly neurophysiologically driven, just have a look at the terminology. We call a peripheral neuron because it has its cell body in the DRG, which is outside of obviously the spinal cord. But one of its central terminus i.e. where it relieves neurotransmitters in the dorsal horn, which is And then we say a dorsal horn neuron. Why do we say a dorsal horn neuron? Because it has its cell body in a dorsal horn. But where does a dorsal horn neuron go? They're the T cells within the classic, pain gate model. They're transmission neurons. They have one end at some point higher up in the nervous system, generally the brainstem, midbrain. Some do go without any synapses up to the cortex. So a dorsal horn neuron has one end in the dorsal horn, has the other end in the brain. We make all these false dichotomies, all the time, and they drive a lot of thinking. Hence the bit of the philosopher comes out in me all the time. That you think, well, I think that we ask people at conferences, we ask people on papers to state any conflict of interest, but I would also get them to state what their philosophy is. And even better is when they can't. That worries me most. Because at least when you know your philosophy, whether you're a reductionist, whether you're a materialist, whether you're a realist, whether you're a brain-centricist or a peripheralist, then at least everyone in the audience can know your biases, will know how you might interpret things. That's not to label you, but that will give you... But when people say, I've never thought about what I think, that worries me, because so many experiments are set up. I've done some work with some of the world's best pain physiologists, neuroscientists, neuroimagers, and they all have a philosophy. They all have a school of thought. They all are part of a paradigm. And paradigms are not about an example. Paradigms are an old body. If you go back to Kuhn's sort of description originally, they're all about the way that you think and behave around a particular topic. Journals are driven by paradigms. What's the acceptable sort of idea at that time? You're more likely to be published if you're adding more information that supports that particular perspective. If you offer something that doesn't, it takes a very strong editorial team of reviewers to push it through for you. Paradigms shift over decades, not over weeks or months or years even. So again, all of those things are sort of there. I'd invite you to every person who comes on to sort of ask them what their scientific philosophy is.
Yeah, and that's one of the things that we had a discussion around that kind of exact topic on social media, because we tend to gravitate towards the paradigm that gives us most comfort and kind of maybe is our way of viewing a particular issue or topic, and we levy a lot less scrutiny sometimes on that. And when we see paradigms that don't maybe align with our way of looking at it, we're much more apt to put more criticism and different things at that. So I think you're exactly right. Understanding your bias and understanding where your thinking lies and beliefs lie around a topic, and how that influences how you're going to interpret things and maybe be less flexible to other ideas, I think is very important, especially when we have folks in research. I think there are most journals, I believe, ask for that. I've only published a few times, and I know you've done it, probably hundreds of times, but I just don't think that's something that the general consumer of research really understands, as far as the importance of understanding those conflicts of interest and these. I love the thought of philosophies, of what's your philosophy around things, just so people can take that into account as they critically analyze and interpret what's going on in these studies.
Yeah, I mean, we have to be careful what we probe, but for I hope a lot of your listeners do realise all the, perhaps say all, not all, but most of the great thinkers of manual therapy across the professions practice, certainly in North America, would have been devoutly religious, and that's a big motivation for why they developed a non-medicinal component to their treatment. Still, obviously, Palmer is still sort of student, but most people don't know that Maitland was a devout fundamental Christian. In his original books, if you own the original copies, look at the first and the second edition, they have a cross on the inside cover, intentional. So, you have all of these subliminal things. It's not mere attacking religion. It's about where and what motivates people, and how does that manifest itself as we go down the line. So, and again, if you like, what are our priors? What we're really getting at here is, what are my priors? What am I tightly adhered to? How is that likely to manifest when I see a particular set of clinical signs and symptoms, what am I likely to associate first with that? I suppose if I'm truly going to be honest about my career, is every time I feel I'm settling into being a proponent of a particular paradigm, I try to move to something else. I try to challenge it, try to go to something different. Try to look at it from a different perspective. Hence, I've gone through all these different stages of my career, and it has made me a little bit sort of where I look outward and think, some of these people who are the next generation have just done one thing and tell you everything from that particular perspective. Much respect for that, but at the same time, there are other perspectives out there too.
Exactly, and especially when we understand this complexity of a pain experience, when we can strip it to a philosophical perspective, when we can strip it down to, psychology, physiology. I mean, there's just so many perspectives, and I think to really get a best understanding, I don't think you can, just stay in one perspective. Definitely, I think, going to the same conference with the same confirmation bias, being patted on your back every year after year, kind of limits your growth as a clinician and your growth as, somebody who's, trying to pursue a better knowledge base around any topic, really.
Yeah, I mean, unfortunately for me, and this may be a question, one or two people, your listeners, I got something against America because I haven't lectured widely in America. But unfortunately, I developed an ear problem which prevents me from flying, including to Australia, where I spent quite a bit of time, and I have a visiting sort of position at South Australia with Lorimer's group. I haven't been able to travel on a transatlantic flight for the last 5 years, so that's been. But the reason why I bring that up is partly to explain some things to a few people I know probably are listening. It's not that I don't want to take up their invites, although I've got to say it's difficult to come to your country while you've got a Muppet in charge of it. So, just wanted to get that across, onto the more accurate thing. But the real thing is that, I say that because you just hit the nail on the head. It's actually been quite liberating as well, not going to things that I'm expected to go to all of those things just to listen to the same people over the last 10 years spouting out the same thing. What's been novel, there isn't a massive amount of novelty in pain over the last 10 years, if I was honest. Particularly in the physical therapy arena, it's just a different shade of the same thing. And make people maybe say, well, isn't predictive processing? So it's very similar to mature organism. Well, it's very similar to the neuromatrix, the neurotag models, and it is, So I'd be open to that criticism. Are you teaching us anything new? No, and in fact, I'd be reassuring to say to some people, well, you don't have to change what you know about neurophysiology of pain, psychology of pain, sociology of pain. You maybe just need to reframe it slightly.
Mm-hmm. Yeah, we could go down to this discussion. I want to.
Sorry to all the Republicans out there.
Oh yeah, no worries. We'll dovetail from the political discourse, but you're not going to find too many arguments, I think. But anyway, one of the treatments that I think is kind of emerging, and I shouldn't say emerging like it's new, as far as maybe emerging, as far as maybe physios are grabbing onto it a little bit more than they have explicitly in the past, is kind of, and I think we've done it in the past without maybe explicitly knowing the knowledge base behind it, but like exposure-based therapies when we're trying to produce expectancy violations. And I just look at that and I see, priors, and we're trying to create maybe new priors by, violating these, these expectancies with patients. Do you see that kind of, it seems to me that fits beautifully within predictive processing.
Yeah, and you've done a better job than I have, Mark, just there, because you've summarized predictive processing perhaps how I should have. If you want to think of it as an expectation reality, then that's a perfect way to think of it. Expectation is the prediction. Reality is obviously, in most cases, sensory input or the treatment, etc. We've talked about where those things, you don't get disharmony, you don't get discourse, you don't have problems where people's expectations match their reality. Yeah? Mm-hmm. But where you get issues is where the reality is not matched by the expectation, or the expectation, goes beyond the reality. So, in fact, I helped develop an appraisal system still used by Deutsche Bank that was based on an expectation reality mismatch for people. When do you get dissatisfaction in a job? It's when people's expectations are so great, the reality can never match them. So they always think they're not getting what they deserve, or vice versa. So perfect way of looking at predictive processing. So where you have a greater generation of error is where reality and expectation don't meet. So the predictions don't match the inputs, or the inputs don't match the prediction. And then something's got to be done about that. And then you're into, adaptive systems within the body. How much flexibility, if you like, still within the system is there for that person to change? So if you challenge somebody's, expectations, you've got to be sure, though, that challenge doesn't exceed their ability to make that adaptation. That's the skillful part of therapy. So, equally, resetting expectation may mean that, you have to redress reality. And so that often, that looks like it may be purely, again, a psychological therapy, but no, it works for behavioral therapies too, very definitely. People say, is this only a sensory system? Not at all. I think people in the motor world have no issue with predictive processing. It's how it's always been done. In the motor world, you think you make a command, it goes down, and then it affects an action. So they're used to this coming first, the downward flow coming first. And in fact, actually, if you look at the modern way that we understand spindles, when most people still go to college, they're taught a spindle's a stretch receptor, But a spindle is actually a very complex organelle, as I'm sure most of your listeners know. It's both thixotropic, so its viscosity has a bearing, but also, the actual descending control of a spindle to either end of the intrafusal fibres sets a prediction of which, with a tolerance built into it, which if you don't exceed, you're fine. But as soon as you actually exceed that tolerance built within that descending control, then you will have an afferent input. So in other words, the prediction is setting that tolerance. Mm-hmm. And I think this is a really good way of looking at predictive processing. It's not saying it sets something really tight, it sets the tolerance for something. If a particular physiological action is happening within that tolerance, the local adaptive systems will deal with it. But as soon as it exceeds that, as soon as in this case the expectation sets the tolerance, reality either is within the tolerance, no problem. But as soon as it's outside of that, you get an error signal, you get something that needs to be done. And in that case, you generate an extrafusal fibre firing. So it's motor. So, perfect model. And those of your listeners, again, I'll offer you some references that look at purely the motor system from predictive processing. Andy Clark's paper with Martin Pickering. Probably 40% of Carl Friston's outputs are about the motor system, actually. Yeah.
And that makes so much sense with the motor system. And, I watch my daughter grow from, where she's just experiencing no priors, and then just kind of watching her start to walk now, and how she was and how clumsy movements are and how they're kind of zeroing in as she's experiencing error and maybe refining some of these priors and different things. My wife rolls her eyes when I start thinking about this stuff. She just kind of tunes out. But I just think it makes so much sense from a motor perspective, as well as you watch motor skill, motor development, all these different things, that it's a really refinement of this whole process.
But again, Andy Clark and I are playing with the term. We're not sure whether we entirely like it, even though it's a term I proposed, and I think he's sort of behind it, but we're still, in a typical philosophical fashion, sort of thrashing. We've sort of termed this perception. So perception and action occur together. So, I think again there, just picking up, and this seems a bit unfair, Mark, because you're the other side of this screen, and, but you said there, when my daughter makes actions, those actions are about about changing her perceptions of the world, about how she understands the world, about experiences, about the sensory world, just as much as they are about making actions on the world. And that's again, this perception comes in. You can't separate temporally or spatially perception and action. They are one and the same. This gross separation of motor and sensory is, I've used that terminology, so I sort of led you down that pathway, so apologies. But we use those terms, but in fact, that clear distinction just isn't there, And again, that probably comes back to why when we want to affect a person, the person, we have many different ways of doing it. I think physical therapists in a beautifully privileged position. We're good. We should be good, and we're improving at our communication and talking and explanation and education. But we're also incredibly good, or should be good, at teaching movement, at making movement less fearful. And, so just because you base your therapy on movement, you can't separate yourself from what you're doing to someone's perception of the world and if you like, their setting of expectations about their world. And that's the other beauty, I think, of predictive processing. It stops you being in one camp. You could say the only camp you're in is the predictive processing camp, but I would say most of the people in that camp are about really giving predictive processing a hard and thorough examination. Likes of Andy Clark, Jacob Hoey, Anil Seth, Carl Friston, they're all part of a research project that's ongoing at the moment that sort of I'm involved in partly, and the discussions in that are brutal about this thing that we're supposed to be proponents and defenders of. And that's a beautiful environment to be in. But some of those people come from a motor world, some come from a sensory world,
Yeah, no, that would be a fascinating discussion to be in, and I think that's what science is all about. It's people not just taking ideas and everybody supports them and props them up. You're trying to tear them apart and to build them up better and improve things moving forward. So I dig it. Mick, I'd keep you here and we could chat probably for hours on this stuff, but you've generously offered us an hour of your time.
No, I've got more time now because I thought it was coming on at... So if you've got more time, I've got more time.
I probably have a few more minutes, definitely, as far as to talk about. I'm just curious, any other ways we can better kind of utilize. We've talked about it from a motor perspective. We've talked a little bit from exposure-based therapies and how they kind of fit into this framework. The nice thing we're seeing is a lot of what we're talking about that might be cordoned off into different thought processes or methods within therapy kind of all nicely fit into this predictive processing model. Go ahead.
Sorry, Mark. I mean, sorry, you have to forgive the sort of, that's the difficulty of us not being in a room together, so and jumping in and that could appear rude. So apologies.
Oh, no
worries. But some of your listeners will be they made what they thought was the right shift for pain, which is to go into the more CBT ACT sort of part of the world. So I've been lucky enough to have close working contact with Lance McCracken, perhaps one of the world's leading psychologists in pain. And Lance and Steve Morley proposed the idea of cognitive inflexibility. And now, people with persistent conditions, but particularly pain in the case of Steve and Lance's work is, they get narrower and narrower and narrower abilities to think, less flexibility of their thinking. They lose agency as well, what they feel they can do, what they have control of. Their whole sort of life is compressing. Now, again, I would sort of say, well, look, that's what we're talking. They're becoming to have what we call hyperpriors, such precise priors that a particular activity, a particular thought, a particular movement will result in pain, that those people, that inflexibility is sort of squashing them. And of course, they, particularly Lance, would propose that the best way to increase cognitive flexibility is through ACT, acceptance and commitment therapy. The proponents of CBT will tell you it's CBT. There's a movement in Britain that marries the two called ACBT, but what I would say is those people who have sort of gone down that road more less the behavioural side, more the, if you like, traditional cognitive behaviouralist side. Again, I think that, and talking to Lance, I mean, he totally agrees. In fact, a couple of his publications now look very much like a predictive processing sort of model for cognitive inflexibility. So therapy there is to try to increase cognitive flexibility. Yeah.
Mm-hmm.
Just the other question that some people ask, if I may, to preempt something, is people say, well, quite often when we hear you speak, Mick, you talk about, decreasing priors, making priors less flexible. Is there ever a time when you want to make the prior more precise? And one of the cases for that would be in low self-efficacy. So in low self-efficacy, I think that what you're seeing a sort of an almost absent prior belief that you can do something to help yourself better. So there you want to treat that. You want to increase self-efficacy. You want to give someone a prior for self-efficacy, for their belief that they can actually make things different. So I think that's quite an important thing to say, because, I'm beginning to put together a series of papers where, I'm going to use some of these probability density functions, some images, to try and demonstrate those therapeutic interventions. And the one thing that people have asked in the past is, what about, people, when we work on the prior? And I think that's what things like CBT do. They mindfulness training allows you to become more flexible, decreases the existing priors you've got, but maybe tries to establish a newer, more accurate, more responsive, I prefer, prior. Yeah, more ability to cope with life type priors.
Yeah, no, I think that fits so nicely with what we're doing with, self-efficacy is a big topic within, research and in what we're trying to move with patients as far as them giving agency, where, like you said, they don't have any priors for agency or control, and we're trying to narrow things into where they feel like they do have some concrete priors of control over their pain experience a bit. And then the folks that are so hyper walled in, and you see that in the motor literature as well, these folks that when we do study after study, and these folks move invariably and inflexibly because they've built these priors of hyper focus on protecting and tensing and bracing and all these things. So again, as you're talking, all these thoughts are rolling into my brain of how this all just makes so much sense with what we're seeing in different, literature, groups of research and different, maybe niches of our practice and in movement and pain. So I think that's awesome. Any other, I'd love to just hear any other thoughts you'd have as far as, ways that we can move forward with predictive processing. It sounds like I'm looking forward to your papers. And I know we've had a lot of feedback already on the folks who are on the chat on the Facebook feed, as far as we'd love if you have the ability to share any of the resources or papers that would help kind of some folks build a better understanding and application of this stuff.
Of course I will. And, and there are other people who have picked up on this, and Todd Hargreaves, who may not be a listener. He's written a very nice blog, which, very kindly sort of acknowledges that he picked up a lot of papers from myself and other people. So, I think, of course we'll share those things. But something that emerged from what you just said was that, it answers lots of questions about everything. And I would say that people like Carl Friston have proposed PPP as a fundamental model of life and evolution. So we shouldn't be necessarily shocked that it covers a lot of these areas. Having said that, is it an all-explaining? Is it the best theory for everything? No. And it would be ridiculous to say that it is. But I think in terms of physiotherapy, if what I would love to come out of my work, if nothing else comes out of my work, I would love it to try and reestablish the balance between those people who've become brain-centric, and I would include some people I've mentioned who are really close to me, good friends of mine are, and I have called them openly brain-centrics. I have that ongoing, banter with my great mate Lorimer Mosley. I think Lozzie's one of the great brain-centrists. Together with Dave, Dave Butler, he's again a great friend of mine, love them to death, but that's also a beautiful privilege of mine that I've got to know these people. They're good mates, but they're also good scientists, and we can disagree strongly, but we're mature enough in ourselves to not let that affect our, relationships. Not that important, but I think if back to the point, if I'm re-establishing, the periphery with the more central construct, and seeing people in a much more holistic way, I think that, that word has badly been abused in the past. I think that that's actually what really I'm trying to get at here is, know when the peripheral stuff, when the lower neurophysiology is important, know when the higher neurophysiology is. But remember, it's a person. All of it's contained in the person. The brain in the vat question is the big thing that I keep posing to people like Lorimer. You take it out, what is it capable of doing? Although there are aspects of predictive processing that would say that the higher centers are able to predict anything that can go on below there. So surely, actually, all pain is in your brain, But why would it construct that without a reason to construct it? And in the predictive processing perspective, it would say you need to have had peripheral inputs to ever learn that you need to make that sort of response. Yeah,
Yeah, and that makes complete sense. Like, if you don't have a sensory apparatus to feed information to the brain, to have any information to go off of, the brain's just a, empty vessel with no information in it that's fed to it. Obviously maybe a little bit reductionist there, but
people have done it. People. I put my hand there. I'm not advocating you do it to your kid, although part of being a parent is having, a small one you can experiment on. But people are very, all joking aside. It's definitely joking. All joking aside, people did those sensory deprivation studies and learned that children didn't develop. They were severely handicapped and severely delayed in both motor and intellectual capabilities. We don't explore our world. If we don't actually make predictions, then act them out, then receive information and make those sort of, sensory prediction, sensory error, motor actions, motor error, this action, which I've talked about, then we will not develop as creatures. And that's inherent in the mature organism model. Louis was very keen of saying, look, all your experiences, that's what you're doing as you mature. What is play? There's some beautiful work that shows if you don't allow children to play, and more importantly, play for long enough, both in terms of single session, but also over their development time period. For some of us, we never stop playing, and those people are the most interesting. The people who still carry on looking for the next thrill, but the next thing to be interested in. And in a way, I'd like to think that might even be what work's about for me. Serious play.
And I see so many applications of just, play, and it makes so much sense from a child development perspective. If you wall off their sensory experience by constraining it to a set, like, you got to sit in this chair and do these things and be exposed to only a certain set, where kids who get to explore and move and get, information from their, and, adjust predictions and do all that stuff to learn and develop as a kiddo, but also makes a sense with patients as far as, I'm not saying we need to go play in a sandbox with them, but have them move novelly and invariably, and experiment with movement. And I think a lot of what this whole novel movement stuff is, it's just therapeutic play. Really, it's just kind of playing, giving the patient to break some of these rigid priors and break out of them, and see if they can form a more expanded prior without it being so rigidly tied to protection and pain and all these things that can happen in regards to. Does that kind of fit with your thought process, or am I way off kilter?
No, absolutely not. You perhaps should be doing this by yourself, by what I'm hearing. But fantastic. Lorimer's perhaps his most influential paper is 2003, 4, 5 paper, We Conceptualizing Pain. Years lost on me now, but I should know that like the back of my hand. But he very graciously sort of at the end of it acknowledges my perspectives that influenced that paper in relation to CRPS, complex regional pain syndrome, and for a period of my career, that's the only patients I treated. They were what really fascinated me, and we do things like intentionally bring them into a therapeutic environment where the first part of that was explained to them that they would come in and they were going to be with other people with the same condition, and they were allowed to mingle and also to make themselves comfortable or they could basically do what they want. And the intention of that, we brought them into what was effectively a play area. And these people who were coming in who wouldn't, they wouldn't be able to wait there. They wouldn't voluntarily use their upper limb. You give them a sandbox, you give them a gym ball to sit on. These people don't realise they're weight bearing as they, are doing what we all do when we sit on one. We're bouncing up and down. They've started their therapy already. Then the gentle thing is to make them realise they're doing that without threatening them. That was the thing. Wow, look at, did you realise what you're doing? What was I doing? And then you often had that immediate effect that I'm sure, you've seen and many of your listeners see. Then they almost do this sort of like recoiling spider thing, then they suddenly realise they shouldn't be doing that. And I used to have those open discussions. Some people, you may be worried that some people think because now you have just done what I've seen you done, that you haven't got what you've come here for, that you're sort of not as bad as you want people to know you are. Yeah? Mm-hmm. And that opened up all of that beautiful discussion. Yeah, I sometimes don't know how to be, because if I'm not how I really feel I want to be at that second, they might think I'm putting it on because at that second I want to do things. But as soon as another set of occurrences happen, as soon as I'm in a different environment, of course I can't do that. And we've got to have a big enough understanding to know why that is, why people can be like that, why someone can pick their bag up off the floor, looks like they've got nothing wrong with them, but as soon as we observe them doing it, then they can't do it. As soon as they're put in a pressured situation, they can't do it. For me, that's perfectly understandable, both on a neurophysiological and non-neurophysiological sort of level. That's not a problem, that's not a punitive thing, and too often it is turned around as saying, well, the patient can't do things. I've picked up Louis, but there's a terrible example in one of Louis's books that I had the pleasure of helping edit with his wife. I read every word for him, and I said, look, I don't like this patient example where he invites the group to look at somebody who didn't respond when they went out the building, and that person looked as though they were okay, but while they were in front of everyone, they didn't. Mm-hmm. That's, a simple point, that's the Hawthorne effect, but it's much more complex than that, And we know that patients often have to, when I say the word exaggerate here, I want to do that with real qualification. People often have to exaggerate their presentation to get someone to believe them. And then often once they're believed, that exaggeration disappears. So I don't even know the proper word, but I don't think it is exaggeration. It's more a desperation. It's a need to get someone to believe, and they're more likely to do that if the person before didn't believe them.
Yeah. Yeah, and you see our history in our profession with Waddell sign and how those were misused and misapplied, grossly. I know, unfortunately, he passed in the last few years, but one of his big issues was the way that it got taken and perceived and applied, inappropriately, to where we're trying to get people to, these folks are malingerers, they're faking, which is obviously they're trying to validate the suffering they're in, is what I would argue with, is that they're not faking, they're just suffering human beings that want to express to you how crummy things are. And correct me if I'm wrong, I think those tests were basically to determine if he was going to have a good surgical candidate or not, and I could be off the path with that interpretation. I think I read that or heard that somewhere. Yeah,
I think they started out like that. I got to know Gordon quite well, Gordon Waddell, and I lectured. One of the places was that we did a series of lecture tours with Paul Watson, very eminent British physiotherapist, and you got to talk to Gordon, and there's a couple of things if you've got 2 minutes that emerge from that. They probably did start like that, but yeah, he did pass sadly, and one of the true greats, and also someone whose work can't have been more abused because of actually his own perspective versus what people then used it to say in the way that you've just said about malingering. So that's the first thing to say. But I would also say that when I lectured with Gordon, I taught with neurophysiology, and the first time we did the course, I was staggered that he didn't really have any appreciation of central sensitization or wind-up like phenomena. He's neurophysiology, and this is not in any way me bad-mouthing one of the greats, but I was shocked at how little neurophysiology he had, and neurophysiology that could explain almost all of his signs he had no appreciation of the potential for allodynia to affect those things, etc. He a couple of them for things like Alf Briggs' work, which Dave Butler picked up on about neural movement, neural biomechanics. In terms of when you do a movement the reverse way, it isn't the same as doing it the same, the other way. It's just not the same maneuver. Also, again, we're back to the perception of the patient, which probably does tie in with these ideas that when they do a movement in a particular way, then that obviously is the thing that they know that they're doing, against when they do it the other way. They don't recognize it as something they can't do. But again, that doesn't mean they're putting things on or malingering. It's just the beauty of again, if we go back to priors, they've got a prior for, they've built up an expectation, using your terminology and perhaps an easier terminology. They've built up an expectation, and therefore the reality is much more likely to be like that expectation when you do things differently. And again, it's the beauty of great therapists. Give people with pain to a neurophysio. Someone who identifies them as a treats strokes and MS. They're some of the best people who have ever been allowed near, people with pain, because they're used to breaking things down, making the same thing, be different. Hand therapists are great. Give a nerve or a radiculopathy with sensory change to a manual therapist. They will probably do a sensory test, but how many manual therapists bother to try to sensory re-educate a person with numbness or pins and needles, paresthesia in their leg or in their arm? I've come across very few. Yet if you think about that in predictive processing terms, then by what hand therapists are doing about desensitization is they're trying to lessen the precision of that prior. That's exactly what they're doing. Why do manual therapists not do that for somebody who's got sensory change? And I would advocate they should, and that's back to why I think a sensory examination for every patient is essential.
You got me excited to go back to the clinic today. I'm actually on my way there here shortly.
Mark, I better leave you.
Yeah, no, this has been great, and I can't thank you enough for, one, being flexible with the time today, and you shared, an hour and a half of your time, and I know you're busy with a lot of projects and different things. And I want you to make sure you have that possible PhD candidate to contact me for that pint of beer I owe them for bumping their schedule a little bit. So I apologize for that.
They're from the US, so I won't mention their name, but they're from the US. But I'll tell them to seek you out. But it's my pleasure, and I'd be only too happy and pleased to come back. And thank you for, on the basis of what I've said, thank you for giving me a small voice in the US. Like I say, that's the reason why I haven't been able to take up the offers. So thanks to people like Sandy Hilton for making offer after offer to me, and unfortunately me not being able to take them up. But if the ear ever allows me, it's a place I actually do really enjoy being. So thank you for allowing me to talk to people.
Yeah, no, it's a voice I think we need to hear over here more and more. And if we can't get it, physically, at least virtually, we can get you here. And maybe, some of the courses I teach, I might bother you to maybe come aboard and help, share your knowledge with some of the physios here and other healthcare folks. So thank you again so much, Mick. I hope you have a great rest of your day. And thanks again.
No worries. Thank you very much. And take care. And please invite me back if you want to, and let me know via the other medium we've talked about how to get references. I can put a load of stuff up.
Yeah, I'll definitely I'll reach out, and we'll see what we can do to get some folks, get some resources in the hands of the folks here that they can use and help improve their practice. So thank you very much.
Cool, and take care of your daughter, eh? And
we'll
make sure her priors are the right ones. All right, take care.
Appreciate it.
Bye-bye. Bye.